Good morning, everyone, and thank you for having us. This is the last time during Sam's PhD that we'll be joining, and I'll be introducing. So it's a bit of an emotional day. It's been a pleasure to supervise Sam over these last 4 years. Really, I guess he's one of the last ones who started in the middle of the chaos that was 2020. We had creative contingency projects that he actually came up with himself. They were his own idea. We finished data collection. We're working very hard to finish that. But yes, besides the academic talent, he's also a pleasure to have around. So really an asset to any lab. And before I give the word to Sam, just to thank MHR UK so much for the support with the studentship over the last few years, not just, as Professor Owen was saying, for the science, but also for giving these opportunities to young people and future-proofing our field like this. So thank you very much. And Sam, over to you.
Okay, thanks for that introduction, Gemma. So I'm going to just launch right in because I've got a ton to talk about. I'm going to be mainly focusing on these 3 projects that my PhD has come to represent. So starting with hippocampal circuit dysfunction and psychosis, this review that I kind of built in the first year or so of the PhD. Then talking about how to integrate different neuroimaging modalities together, and then finally the sort of specific experimental project that I was collecting data for. So I'm the first person in this session. We haven't really talked about psychosis or what psychosis is, so I'm going to just give a very brief background for those of you who are a little bit less familiar. So when we're talking about psychosis, we're talking about the state that encompasses these positive symptoms, things like hallucinations, delusions, disordered thought, possibly the ones that people think of the most, but also negative symptoms, cognitive symptoms. And when we're talking about psychosis, we might be referring to a psychotic disorder, something like schizophrenia, but there's also this gradation of symptoms and severity as well. And psychosis usually manifests itself in early adulthood, but there's also this prodromal period before the onset of psychosis. And one group that we investigate a lot in our lab is those at clinical high risk for psychosis. So those that have attenuated psychotic symptoms, but haven't yet gone on to develop a psychotic disorder or a full-blown psychosis. And so in our lab, we investigate psychosis using different imaging techniques. And so if we think of the scale of going from the behavioral, these psychotic symptoms and different things, we can look at lots of different measures in the brain that we can then relate to these psychotic symptoms to try to understand what's going on and better treat these individuals. So these are a few of the things that we might try to investigate as we go down this sort of scalar ladder. And to kind of guide you through what this looks like in our work, we have these psychotic symptoms, and we might try and relate these to network dysfunction in different areas of the brain, such as the hippocampus. So the hippocampus might become metabolically overactive because of this, metabolically overactive and dysfunctional in these networks, and that might be resulting from different cells and the signals from different cells becoming imbalanced, what we call excitation inhibition imbalance, where their inhibitory cells get damaged, and thereby the pyramidal cells become overactive and cause this networking cascade of effects. So these are the sorts of ideas that I explored at the start of my PhD in this paper. You can check it out there if you want to learn more about it. And that leads me as well nicely into the second project, which is relating these different neuroimaging modalities together. So as I said before, if we're looking at metabolic abnormalities in these disorders, that's happening at this very high level. But there's quite a gap between our understanding of what's going on at this high level and what's going on at the level of the neurotransmitter, where we might be able to better intervene. So in other words, if we think of this, again, think of this ladder, and we have increased metabolism up there, you can see there's quite a gap, between where we might be looking at these more specific areas of dysfunction. And recently, we've been aided in trying to bring these modalities together from these the sort of open science initiatives of these freely available pet-derived atlases. These pet-derived atlases that give us different informations about neurotransmitter density and things of that nature. And so we can relate these two things together to try to understand what might be underlying these metabolic signals. And so, in other words, what is the relationship between resting perfusion? So this arterial spin labeling is what we often use to measure this. These resting metabolic abnormalities and underlying neurotransmitter systems. Or in other words, can we relate these things together? Can we spatially correlate these two things? And does the regional distribution of different receptor systems, does that track the regional distribution of the metabolic abnormalities? So to look at this, this is one of the contingency projects that we came up with during COVID. And we were given access to this large data set of 129 individuals at clinical high risk for psychosis. Just as a reminder about, quite a number of these people will go on to develop a psychotic disorder. And we also have individuals diagnosed with schizophrenia, 122 patients with schizophrenia. And what we get from these individuals is we get these cerebral blood flow maps, these maps of areas that are more or less active. And these are then, as well, just to mention, we have 14 people as well that subsequently developed psychosis. So we have these three groups, those that develop psychosis, clinical high risk, and schizophrenia. And this slide is quite busy, but I'll guide you through it. This is a sort of a pipeline of analysis. So we, rather than just looking at one neurotransmitter map and comparing that with the metabolic abnormalities, we took 19 different PET maps from 9 different neurotransmitter systems. So serotonin, GABA, glutamate, acetylcholine, NMDA, lots of different systems. We have our case control maps of metabolic activity. So we take our patient map and we contrast that with our healthy control map to see the areas that are more different in our patients than in our control subjects. And I'm not going to talk about it today because it's a whole other thing and I don't have time for it. But just to say as well, it doesn't have to be receptor maps. We can relate these things to any kind of brain map. And so we also looked at, from the Allen Human Brain Atlas, 17,000 different genes and related those genes as well to the signal that we were seeing with the MRI. So to do this kind of analysis, rather than look at every voxel, which is a 3D pixel of the brain that you can sort of see there, that becomes quite difficult to do. So to make it a little bit easier, we divide the brain into 122 different regions. And so we basically take our maps, parcellate them out by these regions, and then take the average across that region and use that for our analysis. Now, don't worry too much about what a dominance analysis is. It's a regression model, and what it's doing is it's using these different neurotransmitter systems along the bottom there to help predict the difference in the blood flow that we're seeing in our patients. And so along the top, we have schizophrenia versus healthy control. In the middle, we have our clinical high risk group, and down the bottom, those that transition to psychosis. And so the more red on the bar is the more that these receptors are influencing our regression equation. And what we see in psychosis, or in schizophrenia, pardon, is that we see dopamine D1, by far the most influential in our model. But as well, we see dopamine D2, dopamine transporter, we see GABA A, as well as the acetylcholine transporter coming up as the most important predictors in our model. In those at clinical high risk for psychosis, it's a bit more distributed. So we see a few different neurotransmitter systems, but the ones that stick out the most are NMDA and 5-HT1A. And we thought that 5-HT1A maybe because this is a more heterogeneous group. It's also including a lot of people with anxiety and depressive disorders. And that is possibly partially due to the fact that some of these people are on antidepressants and these kinds of medications. And when we separate it out just to those individuals that transition to psychosis, we see that NMDA is the most important predictor, as well as the dopamine transporter is quite important, and the mu-opioid receptor, which was a bit unexpected and needs to be looked at further. So why are we looking at all these sorts of things? PET is expensive to run. If you're doing a PET study with each of these 19 different tracers in each of these individuals, it's impossible because, each PET scan is about £5,000. Each tracer is radioactive, so you can't be injecting the same person with the same tracer and try and expect to be able to collect this much data on that one individual. So using these methods is a kind of way to freely supplement our MRI analysis, and might become a much easier and cheaper biomarking tool than doing PET in each individual. And it's also hypothesis generating. So by linking these metabolic abnormalities to these underlying neurotransmitter systems, that might give us rationale for new drug interventions or repurposing existing drugs to target those systems. We've just published this in a preprint. If you're interested in any of these methods or any more of the specifics that I haven't had time to get into, I check it out there, but I can also answer questions if you have any. So finally, I'm just going to touch on the last project of my PhD. This is the one that we've been collecting data for. We're quite interrupted with.
And we just have a minute or so left, all right?
Yeah, cool, all good. And so I don't have any data to share with this because we're sort of going through the pipeline now. But just to say, what differentiates this study from the last one is that we're collecting the PET data in the same individuals. So rather than these healthy control maps, we're using gamma maps from the same individuals. And we've got clinical high risk, healthy control, and an exploratory group of first episode psychosis patients. So thinking about the sorts of things that we're investigating, we're trying to link the increased metabolism with different markers of EI imbalance by looking at this GABAergic tracer. So that's currently ongoing. I'm finishing towards the end of the year, so this is going to be the last paper of the PhD, and then it's going to be tying it all together into a thesis. And that's it, really. I want to thank Mental Health Research UK, my supervisors, everyone in my lab, the participants that were involved in the study, as well as the clinical teams in the trust we work with.